Who's starting that?
Yes, it's been started, Councillor Fairhurst.
Thank you. So can I just say welcome to all the board members, and also to, I think, Councillor Glenn, Councillor Perry and Councillor Manns, among others who are attending as observers. I know you've been asked to be muted as an observer, but as I said to Councillor Bolton, if you have a burning question, please put your hand up, and I'm sure we will allow discretion if people want to make comments or say anything. Okay. Can I welcome you all to this meeting of the Health and Wellbeing Board? The meeting is being held remotely. The meeting is being live streamed and will be available for repeated viewing. During the meeting, if a member wishes to speak, they will indicate as requested and we will call them to speak in turn. I'm going to begin by reading the names of members on the committee so they can confirm their attendance for the public record. There's myself, Councillor Liz Fairhurst. Barbara?
Yes, Dr. Barbara Rushton, Clinical Chair of South Eastern Hampshire CCG.
Thank you. Judith?
Yes, Councillor Judith Grajewski, Executive Member for Public Health.
Patricia? You're muted, Patricia.
Sorry, Councillor Patricia Starlard, Executive Lead Member for Children Services and Young People.
Thank you. Graham?
Graham Allen, Director of Adult Health and Care. Good morning.
That's right. Good morning. Simon?
Simon Bryant, Director of Public Health.
Steve? Steve Crocker? Steve, yeah.
Good morning. It's Steve Crocker. I'm Director of Children's Services for Hampshire.
Good morning. Dr. Peter Bibaway?
Yes, good morning. Peter Bibaway, I'm Clinical Chair for North East Hants St Farnham CCG.
David Chivers? Dr. Chivers?
Good morning, yes. David Chilvers, Clinical Chair, Fareham and Gosport CCG.
Good morning. Nicola?
Nicola Decker, Clinical Chair, North Hampshire CCG. Good morning.
Good morning. Anne?
Councillor Anne Crampton, Chair of the Health and Wellbeing Districts Forum.
Philip?
Councillor Philip Raffaelli, Gosport Borough Council, one of the two Borough Council reps.
Patricia? Patricia Hughes? No, she might be joining later then. Christine? Yeah. Christine, you're muted.
I'm sorry, Christine Holloway, a representative from Health Watch Hampshire.
Thank you. Alex, I've just seen you appear, so.
Yeah, I'm Alex Whitfield, Chief Executive of Hampshire Hospitals and representing the acute hospital trusts.
Thank you. Rob Cole, I haven't seen him. Is he here?
Not yet, Councillor Fairhurst, but I think Patricia Hughes just joined us.
Patricia, do you want to introduce yourself?
Hi, good morning. My name is Trish Hughes. I'm Joint Chief Executive at Hart District Council, and for the purposes of this meeting, I am the Chief Executive Representative across the county of Hampshire.
Welcome. And Dr. Rory Honey?
Hi, Rory Honey, co-opted Deputy for Sarah Schofield, West Hampshire CCG.
Okay, welcome. And Anja?
Good morning, Anya Kimberley, Head of Performance and Information and representing Police and Crime Commissioner.
Thank you. Can I just ask, are there any deputies that I haven't called, or members in fact? Is anyone not being called who's meant to be here?
Yeah, Julie Amy's Councillor Fairhurst. Amy.
Sorry, Julie, I knew you were here, sorry, yes.
No worries. Yeah, Julie Amy, Chief Executive, Energise Me, which is a charity that works across Hampshire and Isle of Wight, but I'm here representing the voluntary sector.
Thank you. All decisions today will be reached through a vote conducted by a poll where we will ask you to say against, abstain or for. And we'll ask the officers to call your name, and then if you unmute and give us your response. The vote will be conducted by Democratic Member Services, and the result confirmed before we move on to the next item on the agenda. I would like to remind members that the Constitution standing orders will apply, so please keep your microphone muted unless you've been called to speak. And also to remind you, you may be visible on the screen to the public, even if you're not on the screen in front of you. The public might still be able to see you. And I just think we need to be aware of that, even when we're not speaking. Okay. Smire, apologies for absence, please.
We have apologies, Councillor Fairhurst, from Sarah Schofield, Mark Cubbin, Michael Lane, Sue Harriman, David Radbourne, Amanda Lyons, Dr. Andrew Whitfield, and Maggie McIsaac.
Thank you. Declarations of interest. Can I ask all members who believe they have a disclosable pecuniary interest to be considered at this meeting must declare that interest and decide whether it's appropriate to leave the meeting or not. And I don't think that's ever happened in the past. I hope it won't happen here. If we could go to the minutes of the previous meeting held on the 12th of December. Can I ask if everyone's happy with the minutes, if you've got any problems with their accuracy or not? No comments? I'll take that as...
Happy, thank you, Councillor Fairhurst.
Right, I'll take that as read. We've had no deputations to this meeting. I've just got a couple of quick announcements. I'd like to thank Dr. Nick Broughton, who is left now, leaving Southern Health. I think he's left now, for all his hard work and leadership of Southern Health, and for being a representative on the Community and Mental Health NH Trusts on the board. Can we wish him all the best in his new role at Oxford Health NHS Foundation Trust? I think we're all really sad to see him go. I'd also like to thank Kate Jones, who was our board manager, for all her hard work and efforts on behalf of the Health and Wellbeing Board. She will be missed from this board, but she's going to continue on her role as a policy advisor in adults' health and care. Now, if we could turn to the Safeguarding Adults report, I think this report was circulated via email alongside the agenda. And are there any questions from members? Graham Allen, who chairs the Safeguarding Board, is here to answer any questions on this. So any questions, if you put your hand up or request to speak. Everyone happy? Yeah, I can see people nodding their head or putting their thumbs up, so thank you. Simon, can I ask you to comment on the pharmaceutical needs assessment?
Of course, many thanks, Councillor Fairhurst. So I need to just inform the board that the Health and Wellbeing Board has oversight of the pharmaceutical needs assessment, which we have to do every 3 years, but due to the coronavirus pandemic, that has been delayed. It should have been published in April 2021 with a consultation period during the autumn, but that's been delayed to April 2022. So we'll begin that process next year.
Thank you. I think you need to just stay there, Simon. You can't go away because you're the next one. We're going to look at the Public Health COVID-19 overview and the impact on health and well-being and the outbreak control plans, which Simon is presenting. So over to you, Simon.
Many thanks. So this report is in 3 parts. So it looks at the pandemic context, the impact on health and well-being, which this board is really key to understand, and then the development of outbreak control plans, which have moved on considerably since this paper was written, but I can update. So if I take them in those parts, I'd like you people to notice in section kind of the pandemic context, kind of where we are, just to remind people back in December, and I have been smiling to myself that I got appointed in December and suddenly a pandemic arrived in December as well. Not quite what I planned for my first year as Director of Public Health, but we're managing it very well. And it gives a little bit of context of what coronavirus is. And if you move down to paragraph 11, it shows the graph of the first wave and what the second wave may look like. So we will have heard a lot about the R value and the R number and how we are using that. And we just need to be very careful that we can't construct an R value for Hampshire or a small geography, because it's just not possible. And the other thing we need to remember, R is related to the spread of infection, but also it will be impacted by the number of people who've got that infection, which is low. So we need to keep that R value low, and the high levels of lockdown we have had previously have kept that low. And as I talk about the outbreak plan, we'll see what we're going to manage, how we're going to do that locally to continue to manage the pandemic going forward. So as the pandemic developed and interventions became better understood, we could ease those lockdown measures to further develop our interventions, non-pharmaceutical interventions, to manage the pandemic. And we've seen in the last few weeks different measures being released by the government. We saw more children going back to school. We've seen places open up, which is really important for the economy. And I also remind people, I'm not just the director of COVID, I'm director of public health, and we know that the economy and health are connected, and we need to make that balance really, really carefully so that we can both prevent the spread of infection and also ensure that we mitigate any impact that lockdown has had on people's health in a wider setting. And there's a little bit more in the paper later on. Paragraph 13 really talks about the testing and how that has progressed, and worth remembering at the beginning of the programme, people, not everyone could get tested. So people with symptoms weren't tested, so we didn't know the full extent of the positive cases, but now absolutely everybody can get tested who's got symptoms, and that's really, really positive. And under the outbreak plans, I will now have more responsibility and ability to direct the testing to where we need it to be delivered. So that's really, really positive. As I said, we've moved in paragraph 14 to the outbreak management, and we're moving to a different way, and I'll talk about the outbreak plan shortly. And finally, it should just be remembered, we're all talking about a vaccine. We are developing vaccines. There's a number in development around the world. However, it's unlikely to be available in the immediate future, and we need to just remember that as we are trying to manage the pandemic and use and not kind of rely on a vaccine for our solution, because we are not quite there yet. Councillor Hare, shall I pause there on that section, or shall I go through the whole paper? What would be helpful?
Hang on. Yeah, perhaps if anyone's got any questions to ask about this section, if they could like to ask them now. I can see, oh, Anne.
Thank you, Chairman. Could I ask you, Simon, what are the chances of a second wave occurring in the winter? I know it's occupying the ambulance service, because combined with winter pressures, if we have a second or a third wave in the winter, it may well overwhelm our NHS. And related to that is, what about the logistics of giving the flu vaccination this winter?
Thank you very much, Councillor Crampton. Yes, you're absolutely right. I think we are thinking there's going to be a second wave. Obviously, we're looking at the modelling, and that suggests that that will be likely sometime during the autumn, and we need to prepare for that as both a health service and a system. Apologies for the noise. I'm just my son's finishing his homework. We're preparing for that, and absolutely, flu vaccination is really key, and this board has a really strong leadership role to make sure that we can promote flu vaccinations through winter, because the challenge of having flu and coronavirus in a winter period will be extremely challenging, and we need to make sure we can do that. And I know well, we're working with colleagues in the NHS to prepare for that, but I think this board has a really strong role to promote and be advocates for the flu programme. As I said previously, we don't have a vaccine for coronavirus.
Thank you. Philip.
Sorry, Freddie. Thank you, Chairman. Yeah, I was just asking a couple of questions about the testing and as we move forward, and the ability to test and trace. Are you confident, first of all, that you've got all the testing capability you require? Do you have the contact tracing resources? And there's been a couple of things in the media in the last few days about a delay in data sharing from the centre, and it's whether you're experiencing problems with that, but also a problem in the turnaround, that sometimes when people are asking for tests, they may not even get the test for 48 hours, then there's a delay in getting it. So sometimes the contact testing information is taking 4 or 5 days plus, which really causes a problem. And it's really just those issues.
Okay. Yeah,
sorry, just before you go on,
sorry.
I also understood that Alex's team were testing some rapid trial equipment. I'd be interested to know how that's gone, because I thought that's almost over with now. Thank you, Chair.
Yeah, no, I'll bring Alex in. I mean, it's great that we've got Hampshire hospitals on our patch, because one of the things we noticed, we had more cases locally because Alex and Hampshire hospitals were one of the first hospitals to start testing. So actually we were testing more people, which is really positive. When you look at the data, it looks like we had more cases. Well, it's more about testing. And I'll let Alex talk about the LAMP test latterly. We are, as I said, getting more control over the testing. We are getting more volume of testing available through these mobile testing units, and also through we have mobile testing units currently run by the Army, but we also have more localized mobile testing facilities that can go to different settings. So I am now really able to get a handle on the testing capacity for Hampshire, and then in my wider role in the LRF across Southampton, Portsmouth, and Isle of Wight, to make sure that people can get testing. And you're right, originally there was a delay in getting testing to people because we didn't have the capacity. We've now got that, and we're working really well. And furthermore, there was a delay in getting testing results through, and that was due to lab capacity. And from my role in the Isle of Wight, when the app rolled out there and we're trying to get people tested, the lab capacity was in Northern Ireland we had to use. We've now got Milton Keynes, we've got Cambridge and Northern Ireland. So our national resource for testing has gone up, alongside our local Public Health England labs, which have been running all the time, up to 25,000 cases. So I'm confident that we are getting there, and we've got a piece of work that we're just bringing together to make sure all our testing arrangements are available for use. So how do we make sure we make the best use of all of them, including what Alex is leading as well?
Okay, Alex, did you want to come in now?
Not letting me.
Can you unmute? Yeah. Go on, Alex.
Oh, right. Sorry, it wasn't letting me. Yes. So yeah, our microbiology team have been incredibly innovative. So they got the testing up and running in our lab very early. And then they've been running, as you say, Councillor Raphael, they've been running this 20-minute rapid test and it's very portable. So lab in a van is what they're referring to it as. So the first bit of work we had to do was make sure it was as accurate as the formal lab test, and then that was all signed off. And then the pilot that we're involved with now is the practical logistics of taking it out in a van to care homes and other areas. So we've been running that for a little while, taking it out. So for example, some of the issues that we've come across is in the very hot weather, it discovered it has a maximum temperature it likes working at. So it worked very well, except on one particular day a couple of weeks ago where it didn't. So we're just working through all the logistical bits of using it. But in doing that, we're going out to care homes, testing staff, patients, everybody, or residents in the care home, giving them the result while we're there. And it's going down really, really well. So I think we're quite optimistic this is going to be able to be scaled up to be used much more widely. The third bit of innovation we're doing is the saliva testing, because the current test for coronavirus, these swabs are really quite uncomfortable and people don't like having them. When they've had one, they decide they don't actually want another one. And so the saliva test is a much more user-friendly methodology, and we're testing that at the moment in Southampton City as a part of a partnership with the University of Southampton. So that's the next innovation. Yeah.
Thank you, Alex. And sorry, I forgot. Did you want to come back to Simon before I move on to Patricia?
No, thank you. That was excellent. Thank you.
Okay, Patricia Hughes.
Hi, then thanks very much. I've got a couple of questions, and they're both actually around cross-boundary problems or issues that might arise. So being a little parochial, I take the chance to be parochial occasionally. Herts, a lot of our residents and a lot of Rushmore's residents will use the Frimley system. So there's a question mark around if we're looking at a Hampshire infectious control outbreak plan, how that works when most of our residents will use something outside of the system. And indeed, you know, I'm anticipating we're not putting pitchforks up for people driving into Hampshire from Camberley. So I'm just curious how that works. And secondly, I mean, from a personal perspective, I can say that the testing is working very effectively. So well done to everybody who's got that up and running. Because we had a potential outbreak at our own council last Friday. We did our own internal track and trace system, and all of our staff who were in any potential risk were tested that day with results coming through the following morning at 6 o'clock. So exceptionally great. So thank you very much to everybody. But I suppose the question is again around cross-boundary. The member of staff had actually lives in Slough, and nobody has been contacted from the test and track and trace system, from my staff's point of view, from that potential outbreak. So we have dealt with it internally, and we've dealt with it exceptionally well, and I think the testing has done really, really well. But I'm just curious because there appears to have been a cross-boundary in that case between Slough and Hampshire, and I don't think the information has necessarily followed appropriately.
Shall I come back in there, Councillor Fairhurst? So yeah, thank you, Patricia. It's really, really important that we kind of look at the cross-boundary issues, and we work very closely with our colleagues in both Surrey and in Berkshire to make sure that the system works well. So for an individual case, if they're tested positive, Public Health England will follow up all the contacts as required, regardless of where they live, and even in the beginning of the pandemic, they were following people abroad. So, and we haven't quite got that problem because people aren't travelling. So, a very robust system to track people wherever they live, if they're identified as positive, and if they identify the contacts they've been in contact with. Obviously, the case has got to say who they've been in contact with, and then they'll follow up. And we're working closely with Frimley. We're part of the Frimley system and part of the linking in with those things, and that's part of our outbreak control board, having connections with Frimley, really important for us, and I accept that. And I think the other thing is just remember we're thinking about lockdown in Leicester, but actually it's going to be more on settings. So we may be thinking about how do we, as we've done all along, working with Graham, closing a care home or shutting it to visitors. How do we think about offices? It sounds like you've done in your place. How do we close that down if need be while people get tested, and then open it up if we know they're negative? Or if they're not, we'll make sure that those people who need to be tested and followed up get tested and followed up and isolate. And we need to make sure we really promote the 14-day isolation for contacts, because that's how we're going to stop the spread of this infection.
Right, thank you, Simon. Peter, you wanted to come in.
Yeah, thank you, Councillor Fairhurst. Patricia, I absolutely share that comment, you know, that you've raised about the cross-boundary work, especially from Rushmore perspective. And I think moving forward, I think we, you know, as Simon alluded to, you know, there's obviously that interlink with the two systems, but I think there's something about needing to do something a little bit more than that at a local level. So I think working with the district and borough at that level, I think, is going to be crucial. And I'd welcome offline that we kind of just develop a framework of how we can enact that when needed. So it's much more quicker, agile, and suitable to the response. And perhaps we can have a discussion about that offline.
Yeah, sure.
Okay, Rory.
Thank you, Councillor Fairhurst. It was just in relation, Simon, to point 30 in what is a very helpful paper, and perhaps more a reflection. But obviously, members will know public health plays a key role in prevention of disease, and whose skill sets I'm sure will become increasingly in demand with the formation of integrated care partnerships and systems. It is reassuring to see additional resource into local authority public health teams, particularly because that bucks recent trends. But I hope we don't see a reallocation of our small public health teams to contact tracing at the expense of that much wider public health role that Simon needs.
Shall I come on to the outbreak plan? That's kind of part 3 of the paper. I'm happy to pick that up now. and then come back to the middle bit. Would that be helpful since we're moving to that conversation?
Sorry if I segued you, apologies.
No, that's fine. So the outbreak control plan is the way that we are bringing local leadership to the pandemic. Really welcome that. And as I think Councillor Raffaelli was saying about the local data, so we are getting local data now from a variety of sources. He's perhaps right to say it's a little bit slow in coming through. We now are getting, from Monday, I've now got postcode data. So actually it's beginning to come through, and it's been a little bit of a process there. So I'm now getting all those results. And the outbreak plan sets out 7 themes that we need to kind of lead on. The first kind of is 2 rather large areas: care homes, which is under Graham's leadership, and schools under Steve's leadership. And we're working closely with both of those directors and partners to make sure that we can prevent and respond quickly to outbreaks in those settings. So that's really important. The next area is really complicated. It's looking at our high-risk settings. As you can imagine, with the County of Hampshire, we have an awful lot of high-risk settings. Before this pandemic, I was not even thinking about meat packing plants. I now know where they all are. We know why they're high risk, because actually people can't social distance, people are shouting, and the temperature. So how do we kind of think about things like that? But the high risk settings are numerous and complicated and diverse. We're looking at, in that includes religious settings, it includes transport hubs, it includes national guidance, comedy clubs, all sorts of places where you may not be previously thinking about managing an outbreak. And we, as Roy said, we do this kind of work all the time, but this is at scale and more complicated. So we're very closely with our district colleagues, very grateful for the environmental health officers and the work they're doing, and we're managing those. So as we kind of understand more about the high-risk settings and learning from other people, another high-risk setting is kind of the custodial setting, so the police and the prisons who are working there. The next area is testing, and I think we've talked a little bit more about that. So there's a lot of work on testing, and that's bringing it close to the Director of Health leadership. Tracing, as we've talked about, contact tracing is really important, and that is, I can assure Rory, that is led by Public Health England. We are not doing that locally. That's not a public health function. What in the local authority, what we're doing is supporting that with our understanding of the local settings, and really, if there is a complex setting, working with them to ensure that they prevent further spread and put things in place and seeing what we can do there. So that's working with all those settings. The next area is the data, and as I said, we're getting more data from what they initially called the Biosecurity Centre Playbook, which made it sound quite fun, but actually it's just the way they were getting the data to us at a local level, and now I can log on and get that on a daily basis, which is really encouraging, and that's been around for about 2 weeks now, I think. As I said, I got the postcode data on Monday. So there's a number of things coming through there. The next area is the vulnerable people, and working with Graham and his team again, and others, district colleagues are part of that, to make sure that we can support vulnerable people who need to self-isolate or who are sick. Now, this may be different from the clients that Graham's used to working with, but the shielding list is a start to that, and we need to kind of take that forward, and that's going very well. And finally, need to think about governance. So we have a health protection board that now meets weekly, that I chair, looking at the data, looking at any outbreaks, looking at any exceedances, so any kind of areas that might be a little bit higher than we'd like, and we do some work on that. And then that feeds into a number of boards, but primarily it feeds into the member-led board, which Councillor Manns, as the leader of the council, chairs, which we're reporting into him. But it also links into key areas of work, such as the integrated care system and the local resilience forum. So that's the outbreak control plan, and that's how it's working. So happy to take questions on that part of the paper as well.
Nicola, did you want to come in on this bit? I don't think we can hear you, Nicola.
Thank you, Simon. It was just a question, 2 questions really, around our role as a local care partnership, which is still in an iterative phase of developing and trying to build relationships, and something about our shared accountability for the work you are doing, because I feel like we're going to be tested at various stages in the months ahead. And I suppose my question is how you see us helping and facilitating when there is a problem in our patch. And I'm trying to picture Alex and I on a Friday afternoon getting a message about X or Y. And my second question is something around the shielded vulnerable patients, just to highlight the work Rory and I have been doing across the patch to try and bring our system together to proactively support the vulnerable people in a more joined up way, so that they don't get 5 calls from 6 different people as if we weren't working together. It's proved harder than you realize, actually, because of information sharing, but I'm really excited about it and keen to share with you our work at the next meeting, and hopefully to show an improvement in outcomes rather than just a useful exercise in team building.
Yeah, no, thank you. That's really helpful. So on the ICP, absolutely key, as you say, at a local level, we work together. So both Roshan Patel and Ellen Nicholas are on the Health Protection Board to make sure we make that links, and we talked about that just recently. In fact, I think we met yesterday and saying, how do we make sure we get the NHS links much stronger? And Ellen and I are doing a piece of work very quickly on that, just to make sure the links, as you say, to the local level, so that I know, on a Friday evening, who can I call and make sure that works. So we're doing that. And I think you're right on the shielding and the vulnerable people. We need to get that right. Public Health England asked the question when they're doing the contact tracing to see if someone is vulnerable, and then we need to feed that into the local systems. So I'm really confident, well, the way the contact tracing works, that would work, but we need to make sure that links into your local work as well, because there'll be a different group of people again, and they may become vulnerable for many different reasons. If they've got small children and can't get out of the house, how do we manage that?
Happy, Nicola? Yeah, right. Barbara, you wanted to come in?
Just to confirm really what you've just said, Simon, and actually, I mean, we are doing a huge amount of work with shielded patients and around actually the extra vulnerability that some of the risks of contracting COVID have thrown up. So the shielded group are a particular group of people who are at risk because of their lack of immunity, but there is an even greater group of people who are vulnerable, and more so as in BAME and age and various other different multimorbidities that actually make them more at risk from contracting COVID. And I guess as shielding is reducing over the next month to not being as complete, and I think people are voting with their feet and going out of the house anyway more often than perhaps they should, that will be really important if we get another outbreak, or when we get another outbreak in the winter. So we do need to keep working very much more closely together, I think, on this.
Absolutely, yeah, very keen to do that, and working with Jess and the group she's got. So yes, I'll pick that up with you, Barbara.
Thank you. Julie.
Thank you, Chairman. Yeah, I just wanted to pick up particularly on, I mean, as you can imagine, I've been on quite a lot of calls during this period with colleagues from the voluntary sector, and particularly those that have been supporting our communities and vulnerable, isolated people in our communities. And I know that it would be remiss of me if I didn't raise at this point two particular things that they consistently pick up on those calls. One is about the involvement in the planning for, this next period, or for further outbreaks, or getting, and it'll come up on the next paper, getting back into, the services that they run. They would welcome early sight on some of that planning. But the second thing is that where they do play and have played a very important part in the response to COVID, is that some of them are really struggling, and they're really struggling financially, because they're eating into reserves, because they've immediately turned around to respond to COVID and can't run the services that would generate income to be able to support that work. So that's a real concern that we need to think about when we're planning for supporting the continued support to our communities that are shielding or socially isolating.
Yes, sorry, you're right. I think the voluntary sector and recovery is key. So it's something we need to think about as a board. How do we think about recovery in the broadest sense and make sure that it's not, I've in the paper, which we don't need to go through, but I've put some kind of early indicators of the health impacts of COVID, the wider health impacts rather than just the COVID. But actually, when you think about recovery in general, and how do we think about the voluntary sector and ensure that we have a really strong community going forward, not just think about recovery from a health perspective, but a holistic approach, which I'm sure we'll be taking. So yeah, that's really, really key, Julie. I do get that. And happy to provide any advice to the voluntary sector on the guidance that says what they can and can't do. And I was on a call yesterday trying to advise people in the beauty industry. It's so complicated, the guidance. I am aware of that, and we're trying to respond to queries, but there is guidance out there.
Right, Christine. Christine, do you want to unmute yourself?
Sorry, everybody. Yes, I have 4 points I'd like to make briefly. The first one links in very well with what Julie and Simon were just saying, which was that we've been thinking that one of the results of the virus and the lockdown and people's experiences is, of course, going to be that the way services are delivered into the future is going to change. And so we wanted to say, let's be really careful when we're thinking about which of the sorts of changes are going to, it makes sense to continue into the future, like, for example, video consultations. Let's take into account and work with the public and patients and users to learn what their experiences has been during lockdown and make sure that any ways that we reconfigure services take their perspective on board rather than only our perspective in terms of what we can deliver. So it's a plea for involving the patient voice in reconfiguration and long-term planning. One of the things that the 4 health watches across our ICS area have been doing has been surveying people's opinions. And I've put a note in the chat saying I'll send you a copy of the survey when it's published next week. But what I can tell you immediately, they asked about access to information and they also asked about people's experiences. And nothing that has come out of it is going to be a big surprise, I think. But there are a couple of things that are worth mentioning. One of them was that they apparently found it most difficult to get information, digital information, from GP surgeries and their websites, which have been widely varied in efficiency, and have asked, could there please be more information about what was going to happen to them if they turn up for an appointment, which ties in exactly with what you were saying, Anne. And they've also been having problems finding out what's going on about dentistry. And as you would expect, lots of people worrying about mental health and how to access things. And interestingly, they've said it's been very easy to access support from voluntary organisations. And I don't think that's a biased sample because it's just a random collection of who there was. My third point was about things that I thought weren't mentioned in your reports, Simon, unless I've missed them, in which case I apologise. One of them was that I couldn't see anything about the impact on Black and minority ethnic people in your report. Now, I know that that's not a large proportion of Hampshire's population, but nevertheless, it's a significant proportion, and in some districts more than others. So I was wondering if we had any information about that and if Hampshire had been doing any work on it. And the other thing is to say that, of course, one of the other things about coming out of lockdown is enabling people to socially distance, enabling people to keeping our air clean so that air pollution doesn't add to people's the poor consequences of catching the virus. And I wanted to say well done to the County Council, who got 100% of their allocation for allocating road space to walking and cycling and making other emergency measures. So well done to the County Council for their response. And could we please make sure that we make a link between people being able to walk and cycle without infringing 2 meters, and all the other long-term planning that we're doing about outbreak control.
Yes, yeah. I'll put those pieces up, Councillor Fairhurst, now.
Yeah, yes, do go, Simon.
If I start at the back end there, you're absolutely right. It's really exciting that we've got some money for converting some of the road space to cycling, walking from a public health perspective and active travellers perspective, making sure we make the best use of that for health and wellbeing and thinking about those things. And we're very linked into the recovery programme for Hampshire County Council, led by Stuart Jarvis, Director of Environment, Transport and Economy, and he's very well cited on the health benefits of that. You're right, the disparities report I think wasn't out by the time I had to write this paper, but it is really important. We don't have local data on that, which is probably was the other reason I didn't put it in the plan, but it is really important we look at the disparities paper and make sure that our plans for preventing further impact of COVID really understand that. And we know it's Black and minority communities, males and older people particularly who are at risk, and those with long-term conditions. So we are doing some work both with the ICS and working with the NHS and locally in the council, so that kind of bringing all that together is really important. And the outbreak plan, although I said high-risk places, it does also mention high-risk communities as well, but we don't want to kind of label them as kind of your high-risk community. That's not a very helpful way, but actually we are working with them and making sure we can support them in the most effective way.
Right, thank you, Sam. Keith, did you want to come in with a question? Councillor Mills?
Yes, thank you very much, Liz. I just wanted to make a couple of comments. First of all, backing up the information that Simon has provided. He is a key individual in our success in Hampshire in the future. I'd like to thank Christine for her comments regarding the County Council and cycling lanes and the other things that go with it. I think the new normal is going to be different to the old normal when it comes to transport generally, and it's a matter of how quickly we can move in that direction. And I'd also like to thank, through you, Chair, all the voluntary sector help that we've had in Hampshire. I think it has been a real success that people have just got on and helped with their neighbours and helped in all sorts of different ways and just got on with it without actually being told to do anything. That's great, and I do understand the point about the funding running out for all the normal activities that charities carry out. I just want to make 2 or 3 general points which I hope are helpful to everybody. I always believe in situations like this, you need to have a clear idea of what the objective is. Now, I said very early on in this crisis that the objective was to reduce the spread of the virus as much as possible. And I was delighted to see that eventually it appeared on the lectern in front of the person from the government giving the daily press conference. In this case, when we're talking about possible future small outbreaks, I think the key objective is to identify as quickly as possible the hotspots, because the quicker we identify them, the quicker it is to find solutions which minimize the inconvenience to everybody. If you want an example, I would hope that we'll try our very best not to end up in the Leicester situation, because if you can actually identify small areas, you don't run into the sort of problems they're doing at the moment as to where Leicester ends and where the countryside starts. So I think that's really important. And I think in a link to that objective is to have a clear idea beforehand exactly how you're going to deal with the different levels of outbreak. So you've got a clear line to take. Now, if you're going to do all those things, communication, communication, communication. It's vitally important that we don't live in our silos, that we interchange information as quickly as possible. And IT generally, I think, has been a real success in this crisis. It's shown a way forward, which should all allow us to work more closely together and to interchange information so that we've got as much information as possible to make the right decisions. And as I say, I totally support what Simon said. I just want you to know the people at this meeting that the need of the County Council is right behind this community way of operating, working together regardless of where we come from in the community, because I think that's the best way that we can ensure that Hampshire deals with any problems effectively and has a good result as a result. Thank you, Chair.
Thank you, Keith. Barbara.
Thank you, Councillor Fairhurst. I just wanted to come back to Christine and Anne around the GP practices and dental practices. So there are such procedures that are called aerosol generating procedures. And of course, that involves anything that a dentist does with a drill. And so for the safety of patients and for the safety of the dentists, they have had to become a very minimal service, but they are gradually being able to open up now. That's very sad, but of course, it's to prevent the spread of infection. As far as GP surgeries goes, they've never been closed, but actually they are doing what we call total triage, where actually it's really important that people contact them first, and then their problems can often be dealt with remotely for the safety of the staff and the safety of the patients. And that can either be a digital contact or a telephone contact. So most people can manage a telephone and some people can manage digital, and there is choice. And these sorts of things have been really, really helpful. And I think you mentioned, Councillor Manns, how digital has come to the fore. It does, of course, present some difficulties for some of the population that can't manage digital, and we have to work our way around that. There is, in fact, some fresh comms coming out to practices to put up on their websites, Christine, that I'm signing off today, and hopefully that will make it clearer. Unfortunately, there have been some national messages that have made it quite difficult for us to go out locally, separate from the national voice, but we are now overcoming that. And as you've just mentioned in the chat bar, Sarah Grintovich is working with the Citizens Assembly across Hampshire and the Isle of Wight around actually finding out those views on what's gone well and what's gone less well. So hopefully we'll be able to publish that too soon.
Thank you, Barbara. Judith.
Thank you, Chairman. Yes, I really just wanted to endorse what Councillor Manns said about communication, and it's something that Simon and I have been discussing, well, every time we speak, I think. We've got to keep getting the simple messages out to people about hand washing, social distancing, and whilst we've got to get the economy going, do we need to go to the shop every day, or do we need to go once a week? That sort of thing. And I think throughout we need clarity, absolute clarity, and also that communication needs to be joined up too, so that we're all giving the same message and that people do not forget that we are in the middle of a pandemic.
Thank you, Judith. Christine, did you want to come back at once? Christine?
Yes, very briefly to say, Barbara, thank you for what you said. I don't think people were complaining about the service they received. They were just giving feedback that it was sometimes quite particularly difficult to find out about GPs and about dentists. But tying in with what you were saying, one of the rather interesting and surprising findings, which I didn't quote because I wanted them to go back and check, was that of the people who did reply to the survey, people had positive experiences about remote access, whether it was telephone or video conferencing.
Thank you, Christine. Simon, shall we come back to you now?
Yeah, many thanks. Those comments are really helpful, and I think we absolutely need to engage with the community, as both Councillor Gruevski and Councillor Manns have said. We are thinking about how we do the comms, and as part of the resource we've been given, that as a key piece we need to do, and we are working that up. So please be assured that is a key part of the plan. The final part of the paper was really looking at the health and well-being context. It's a very early stage because obviously we're learning, and paragraph 16 through to 30 through to 23 really show some of the impacts, both mental health and physical health, on that. And I know that other colleagues will be seeing impacts on children's safeguarding, adult safeguarding, those things. So there's a number of impacts we need to be really mindful of. I suspect this will be an on-running kind of piece of work, which might be helpful to have a really full report next time as we understand more of the impacts and we get more data through. Would that be helpful, Councillor Fairhurst?
Yes, that would be very welcome, Simon. Thank you. Shall we go to your recommendations now?
Please do. Yeah.
And I think dams are going to take over at this stage and run. Is that right, Samaya?
Morning. Yes. Hi, Councillor Fairhurst. It's Katie in Dams. I'm going to look after the voting side. Hi. Good morning, everyone. So obviously the recommendations for this are for noting, but we'll go through just so we can get an idea of how we're going to do it for the meeting. So what I'm going to do is I'm going to go through the options, and then if you're happy to speak up if for which option that you'd like to go for. So we've got anybody that wishes to abstain? No. Anyone that wishes to go against? Okay, so I take it that everybody is in favour of the recommendations. So if I could just get a general verbal hubbub of agree, that would be fantastic.
Agree.
Brilliant. They're carried. Thank you.
Thank you. And Simon, thank you very much. It's a bit longer than we meant it to be, but it was well worth doing, I think.
Thank you very much.
Thank you, Simon. Can I ask Graham now to talk about our care home support offer an update? Graham?
Thank you, Councillor Fairhurst. Colleagues, what I'd like to do is to share a presentation which hopefully is just coming onto your screens now. Just as that's loading, you will see within the report packs there is a copy of the presentation which covers this item and indeed the subsequent welfare response update. I'd really like to use just this presentation rather than going through the report section by section, just to draw out some key elements from the report overall, hopefully as a way to prompt some questions, but I'll be relatively brief. I'd just like to say one thing before I get into the presentation, which is just to give a resounding thanks, which is small testimony to the absolutely amazing work that we've seen across all of our organisations through responding to COVID. I'm particularly drawn, and you'll see it within the recommendations of the report, around the humanity, compassion and care across the health and care sector. And I really want to draw that out because this report, as you are aware, is around care homes, and care homes have come under a great deal of media attention and scrutiny nationally. And I want to give an overview of the situation in Hampshire during the course of the pandemic, and indeed where we are now and the direction that we continue to travel in. Firstly then, I just want to share with you the timeline. I won't go through this slide in particular detail, but I think it is just important to recognise that timeline in terms of the pandemic being called by the World Health Organization in mid-March, the speed and also the veracity of the impact of COVID through March and April, and indeed the response from many organisations, and huge testimony and credit needs to be given to the voluntary community sector. We will say more about the voluntary community sector in terms of the welfare response update, but we've seen across all our communities absolutely phenomenal responses, and I would say none more so than in the care sector, and particularly the care home sector, which has been particularly and significantly impacted by COVID. In terms of some of the key issues and some of the key data to share with you this morning, in terms of what we've seen over the period, so from late February through to around about the middle of June, and the reporting lag is due to the notification around deaths, but in that period we've seen some 1,672 deaths in all care homes across Hampshire. There are almost 500 care homes in Hampshire, and there are almost 13,500 care home beds. So a very significant impact over the period. It's important for me just to draw out a couple of points. The second bullet point, and I'll get into a little bit more detail on the next slide, of those 1,600 or so deaths that we've seen, 27%, so 449 of them, have had COVID-19 identified as the cause of death on the death certificate. And overall, 203 care homes in Hampshire at the time of drafting the report, so that's 41%, have had either a confirmed or a suspected COVID-19 outbreak. Now, it's important to recognise that it's 41% of care homes, not all care homes. And some of the learning that will need to be developed over time, and there's work underway to get under the skin of this and understand it better, is why 41% and not all. And that will be important learning for us as we go forward. This next slide, though, I think is absolutely key, because what this points to is those COVID-19 deaths where there's a mention. It may not be the primary cause of death as notified on the death certificate, but it's mentioned on the death certificate. The purple line you see is the usual or the normal number of deaths we see week on week across the county's care homes. So those 499 care homes. These are the purple line, demonstrates the number of deaths one would imagine that we would expect to see in an average year. The grey line and the blue line are then the deaths that we've seen in this year. Now, the important thing is, as I've said, the blue element of the bar is where COVID is either the cause or mentioned on the death certificate, and the grey line is what's termed as excess death. And the excess death above the purple line is the vitally important thing that we will need to understand as we go forward. So why did that number of people die if they didn't die as a result of COVID? And there is work underway across our organisations, again, to understand what the causes in those circumstances were. And of course, it's really important to acknowledge and recognise that each and every one of those deaths is a tragedy for the family, but also for the care setting, because care settings operate like family groups in many, many ways. So I do just want to, again, draw your attention to the impacts across our care sector in Hampshire. In terms then of some further updates in terms of what we've done, and I apologise to a degree, but not wholly, some of this comes from a Hampshire County Council perspective, as you would expect of me as the Director of Adult Social Services, in terms of actions that we took. So very quickly, we undertook to uplift income levels to domiciliary care and also care home providers. And there was a wider range of measures, but what we recognised very early in terms of the COVID-19 impacts was the financial impacts on providers of care were likely to be significant. And we acted swiftly to uplift domiciliary care by 5%, paid in advance without anything further for those domiciliary care providers to do. And that was 5% uplift based on commission care. And similarly, for care homes, where the local authority commissions, we uplifted by 10%, again in advance payable on the first of the month without any additional requirements from those providers. I'm aware that colleagues in the NHS, in terms of continuing healthcare funded placements, have followed suit. We also established very quickly regularised arrangements to support the care sector with a particular focus on the care home sector. And as Simon has already said, some of that is absolutely part and parcel of what we've now got within the local outbreak management plan around the monitoring of outbreaks, but also the provision of specialist support and advice. So very positively, colleagues from our CCGs absolutely made sure that infection prevention and control information and advice, along with other colleagues, was being available and provided, and indeed access to additional support was provided around managing the potential outbreak in the care sector. We also made access to emergency PPE available. As I'm sure you will have all recognised in the media, the issue of PPE was a major issue from the get-go in terms of COVID-19 and response to the pandemic. So just in terms of some insights, and these aren't particularly insightful, but just important just to draw out within this presentation. The response to COVID-19, we've not needed to respond to a pandemic in this way previously. And despite all of the work that all organisations do as a matter of routine in preparation for major incidents, the scale and the scope of COVID was something that we could not have rehearsed in advance. We've been running in terms of response now for the best part of 4 months. We are still in major response mode. So we are still dealing with and fighting the pandemic. There's no two ways about it. We also have some particular characteristics of COVID-19 in terms of the transmission vectors, but also the fact that many people may present as being asymptomatic. It's a new novel disease. The impacts of infection, and again, this is borne out both by national and international evidence, they're being learnt as we're going along. Again, it's something that was difficult to imagine before we started being able to respond. And also the transmission profile. We saw a rapid escalation in the early days. We then subsequently had lockdown, which saw the incidence starting to reduce. But it's still clearly a clear and present danger in terms of transmission risk. We also, because of it being a new and novel disease, had some issues with regards to some of the national supply chains around personal protective equipment. Very rapidly, the health, social care and wider sector needed to ramp up in terms of the access to PPE. We also needed to very quickly be agile and adjust to different and changing guidance in terms of the types of PPE that were to be used in different circumstances. And there were some very major challenges in terms of access to PPE, given the fact that this was a global pandemic and market forces meant that actually at times it became very challenging and very difficult through usual supply chains to obtain PPE. We also had some issues around testing in terms of being able to, at scale, test environments and undertake whole sector testing. And certainly within a care home setting, whole home testing for both residents and staff has been something which has been vitally important. And I'm really pleased to report that we now have had whole care home testing undertaken for residents and staff. And certainly within the local outbreak management plan, that is an ongoing issue because testing once is unlikely to be sufficient. We need ready access to regular testing as we go forward, given some of the concerns. We've also had some major impacts quite clearly through lockdown and the closures of communities. I'm talking not only about geographies, but also communities of interest in terms of care homes. It's really important to understand that the care home sector moves swiftly to protect residents and close to visitors, but the impacts of those measures have been profound in terms of access to families, people who have been towards an end of life phase, not having direct access from visits from family members and others. Very, very significant impacts. And these things will travel forward with us for some considerable time in terms of the emotional, psychological and mental health impacts upon residents, families and staff. And as Christine identified earlier from Simon's report, there are other factors that we need to take into account. So concerns and safety for some of our key workers. And across the NHS and indeed within social care, there are a high proportion of colleagues from Black, Asian and minority ethnic backgrounds. And certainly the sector has had to both protect, but also work very hard to reassure those individuals and those communities within our health and social care workforce. That will continue as we go forward. Some of the things that the sector have reported, and the Hampshire Care Association undertook a survey of its members. Again, I won't go through any of the particular detail on this slide. I'll let you look at it. It's just to draw out, certainly from a sector perspective, these are the kinds of issues that they've been working very hard to mitigate, to manage and work through as they've responded to COVID-19. What we've done more recently, so government announced a national fund, a grant of £600 million to control and support infection prevention and control measures in care home settings. Very positively across the county of Hampshire. We've got very strong, very positive relationships with all organisations and all partners. We were able to move very swiftly, building on what we put in place from the get-go in terms of response to COVID, to establish a care home support board. And that's made up of colleagues from across Hampshire County Council, including Public Health Function, from CCG partners, from Hampshire Care Association, which is a representative body for care providers across the county of Hampshire. And that's also supported by colleagues at Health Watch Hampshire and the local CQC. And we were required as a local authority to ensure that by the 29th of May, we had developed and published a response plan to support care homes. I'm really glad to be able to report that we were able to do that. The response that we made to government got a rounding endorsement in terms of positive endorsement for all of the measures that we put in place, and indeed some of them have been identified as best practice nationally. And we were also able to distribute funds that Hampshire County Council has received. So 2 tranches of £9.2 million. Payments were made totaling some just over £7.8 million to every care home setting in Hampshire in the first tranche. And Hampshire County Council took a view that it was important to get that support out to the sector in advance of receiving the government grant funding. So the County Council went at risk and made those payments by the 29th of July. And at the time, it was in advance of receiving the government funding. I'm pleased to report we've subsequently had the government funding, and we're now in the position of preparing to make the second payments. We've also got clinical leads identified for every care home in the county, and also every care home has a named primary care practice that is providing support. And we've got multidisciplinary team meetings happening around all those residents in all those care home settings. So just in terms of where we are and where we go forward. So by last Friday, the 26th of June, we needed to submit a return based on that first tranche of funding. We were able to do that very positively. The funding that we've received through that government allocation is subject to actually quite stringent grant conditions, which lists permissible spend. All care homes submitted a return to us, and it confirmed that they had indeed spent all of that money appropriately. As we go forward, as I say, the second payments are due to be made from next week, again to all care home settings. And we've commissioned some work both through the Hampshire Safeguarding Adults Board and through other mechanisms to undertake work to learn lessons from wave 1. And some of that, as I've already indicated, will be around those excess deaths that we've seen within care home settings. And at the same time, and again, this is the unique thing around COVID, the sector and indeed wider is planning to both be restoring and recovering from the first wave, but also planning for a potential second wave. And of course, this is extremely challenging for the sector as we go into the autumn and into the winter. Thank you very much. I'll pause there.
Right, thank you, Graham. Any questions for Graham at this stage? Philip.
Thank you, Chair, and thank you, Graham. It's a very illuminating report, and I guess it must have been quite challenging to write it where we are just now. I don't want to go into too much detail about the stats, but there are a couple of things that slightly confused me. On paragraph 16, you talk about the expected deaths of 50 to 30. I think you meant 50 to 80, because that would be better reflected by the graph that we saw yesterday evening when you sent out the analysis. And then if you look at your Appendix 1, some of the figures don't quite add up. Your non-COVID numbers are 1,248, but it says 880. But that aside, because those are in the public domain, the thing that I'm not clear about, and you perhaps could illuminate, is up until about the week ending 3rd of April, we were pretty much running along expected if it was 80 being your upper limit. But you then get this jump of both non-COVID and COVID cases. Putting, for the sake of this question, the COVID bit aside, because I don't know what the numbers were in the care homes, whether they were a raise considerably above average, it's whether these deaths were deaths that would have occurred anyway, but more expected to have occurred in the secondary care setting rather than the care setting. You get where I'm coming from. So I'm not sure if what we're seeing is an overall increase or something that happened unique to the care homes. And yeah, that's going to be really important to tangle out as you go forward with your lessons learned. But that's the question. Thank you.
Yeah, and I think it's a really good question, and you'll appreciate at this moment in time, I can't give possibly a definitive answer to the question. What we do know is that routine testing and availability of testing in terms of COVID really started to commence from around about mid-April. So one of the issues that we know is likely to be present is actually some of those deaths that we saw as the number of deaths started to rise. It may well be that people had COVID, but there was no way of being able to determine. So it's the thing that we don't know. The other factor that we've got is, and Alex and other colleagues may be better placed to respond to this. What we saw through certainly early to mid-March and indeed beyond was a need to prepare for surge planning in our acute hospitals. And we saw a very rapid movement of people from acute hospital settings in order to create that acute capacity within our acute settings. And of course, what we know is a usual discharge route for many, many people will be from an acute hospital setting into a care home setting, whether that be for a short-term step-down placement or indeed as a permanent admission. So I suspect there will be a combination of factors that led to that massive sort of ramping up. And with regard to the data, yes, you're quite right. At the time of writing the report, I had 1 year of trend information. And as it says in the report, there's variation from year to year. The graph that we've now put into the presentation is the average over a 3-year period of the number of deaths. If I look back to the 2019 spring, it was in the range of 30 to 50 people on average. But there is variability, and we've taken that average over the period.
Thanks very much.
Thank you. Alex.
Yes, thank you. I was going to ask on the same theme, really. So the first thing I would say is that the excess deaths that haven't been identified as COVID are not just a shift in location from hospital to care homes, because even across the country, the excess deaths, including deaths in people's homes, in care homes and in hospitals, are not fully explained by the COVID deaths. There's, only half of them are. There's a huge additional excess deaths, irrelevant of location. But I think the bit that there are a number of bits that I'm curious about. So one is, as Graham says, the COVID, they may have had COVID, it just wasn't identified, although actually doctors signing death certificates were not, do not only rely on a COVID positive test. If they think they've got symptoms, if it looks like COVID, they can put that on a death certificate without a positive confirmatory test. I'm not sure, we need to do the work. I'm not sure how many would have been people who would have been sent from hospital to the care home and then subsequently died, who might otherwise have died in hospital. But I do worry a lot that some might have been people who would have been sent into hospital from a care home, but because there was, we were still accepting people who were critically ill. We absolutely were across all of our hospitals. But I think the media presentation and all the rest of it was, please protect your hospitals, don't send people in unless they really need to. And I sometimes worry that between all of us, we maybe kept people in care homes. But I think the other bit of interesting bits, your graph doesn't take us out to current time, Graham. It stops a couple of weeks ago. But if you look at the national graphs, the deaths that we're experiencing in the last couple of weeks have actually been lower than the typical. And so part of my question is, some of these people who died so unfortunately in March and April and may actually have statistically died anyway in July, August or September. And so it will be interesting for us to see when that excess death curve actually kind of resets and you end up saying, looking over the year, we perhaps haven't had very many or even any excess deaths. It's just they happened earlier in the year. And I think that will be an interesting piece of analysis to understand. Really sad for every single individual and their families, but from a statistical perspective, interesting.
Yes, and certainly what we've seen in recent weeks is a lower level of death in care home settings, as you say, Alex. So, you know, the issue for us is the learning lessons will take us some time to compile, and arguably will never be complete on the basis there'll be further information that comes forward that we'll need to take into account. But it's a piece of work, as I say, or a number of pieces of work that we are currently undertaking, and I'm keen to bring them back here and indeed to other places in due course.
Christine.
Hello, thank you. Well done. It must have been absolutely nightmare, the whole thing in care homes. And I do appreciate how busy everybody is. I just wanted to ask how you're getting on with making sure that people in care homes have personalised support plans and death plans, so that they've got a plan in place that reflects their opinions and those of their family and the people who care for them. Is that something that you've been able to ramp up because of thinking there are more deaths coming, or has it gone by the board because everybody's been so busy with everything else?
No, it's certainly not gone by the board, and indeed part and parcel of the care support plans that have been produced at a national level in terms of strategy that's come through, for example, my own association, ADAS, has been around ethical care in care settings. And actually what we've seen is the sector move as one to much more focus very quickly to supporting ethical decisions around supporting people. And indeed, Christine, you will be aware of work that Health Watch is now undertaking in terms of working with residents and indeed families within care home settings in terms of obtaining their views, which is why we've been really, really keen. And I'm really delighted that Health Watch Hampshire have joined the care home support arrangements that ourselves, the NHS and others have put in place. It's vital that we keep the voice of the resident and the family at the centre, and indeed part and parcel of the learning is to understand their experiences as we've worked to COVID.
Simon, you wanted to come in.
I put mine in the chat, but Alex is absolutely right about the excess death issue. We'll do that as we do our piece of work to look at the impacts of COVID on health and well-being. So we'll be doing that.
Super, thank you. Anne.
Oh, thank you, Graham. Can I just ask, has there been the usual number of people moving from the community into care homes, or has that decreased as a result of COVID?
So we continue to see people being admitted into care home establishments. The numbers are lower. There's no two ways about it. And in fact, one of the major concerns for the care home sector, not only here in Hampshire, but nationally, is the level of confidence that the public have in terms of care homes being appropriate, safe and caring environments, given some of the national coverage we've seen in terms of what's taken place in care home settings. So people still are being admitted, they're still choosing to enter care home settings, but the numbers currently are lower. And there is a great deal of work taking place by Hampshire Care Association and indeed other representative bodies across the country to kind of reinforce that view that care homes are still safe, they're still open, and they're providing the highest quality of care, but the numbers are slightly lower.
Barbara.
Thank you. I just wanted to say a big thank you to Graham and his team, because it has been an amazing piece of work. And I think the infection prevention control and all that has happened from health has been supplementary to what has been happening with Hampshire County Council and their management of care homes. So thank you, Graham. as far as you were talking about care plans, Christine, Graham mentioned that every care home has now been aligned with a general practice, and my colleagues in those practices have been working with care homes weekly as a weekly touch point, and have been constructing with the families and the residents care plans that are comprehensive and actually reflect the wishes of each individual in a care home, and they're now accessible digitally to people like paramedics who might be called. So should they wish to go to hospital, it is now possible that those wishes are front and centre and everybody knows.
Thank you, Barbara. Rory.
Barbara sort of beat me to it, but Council Affairs, but really to say, I think the National Primary Care Network Des was very prescient in the sense that the working relationship between primary care and care homes, that nominated lead, is been crucial through this time, and I think is providing an excellent level of care for the care homes. And just on an individual level, to thank and reflect staff in those care homes, it's easy to look at the statistics, but actually individual stories of members of staff staying and camping on site, whether they've been ill and coming back in, it is really quite moving. So just to reflect that to all the membership.
Thank you. Philip.
Yeah, Chair, I'd just like to say it's opening up Woodcote Lodge in Gosport, I think, has been a really positive facility. The step down, a really good move. What kind of position is it in just now? I know it can take initially up to 54. How busy is it?
So it's increasing in terms of people entering Woodcote week by week. I'd need to double check, and I can try and do that once we take a break this morning. I'm aware as of last week we were into double figures in terms of people that had been admitted. So as you'll appreciate, it's a new environment that we've opened. In terms of admitting people, we've wanted to take it in a measured, cautious way, and indeed it's kind of building on existing programs of discharge support. What it does for us is it clearly provides an opportunity for people to be safely kind of cohorted and quarantined in terms of a step down facility, and then hopefully as many of those people as possible will return to their own homes. But it's providing that additional layer or level of support prior to that happening. And I can, as I say, I can double check on the current admission numbers when we take a break.
Well, thank you. I think it's a fantastic initiative. I know it's funded till spring of next year, but wouldn't it be nice to keep it in the longer term once this is all over as well? Thank you.
So certainly, I mean, it's a really important point. Work is continuing in terms of learning lessons. We need to understand how well it's doing what we hope it does. And in terms of then the medium to longer term future, we will base it on that evaluation. But I would be keen that we support it, subject to it doing what we need it to do.
Right. I think Graham, I think you've almost come to the end of this bit. Shall we just go to, is there anything else you want to add before we go to the recommendations and ask Katie to take a vote?
No, thank you very much. No, that was it.
Okay, Katie?
Thank you. So yes, we'll go to the recommendations that are on page 29 of the pack. So do we have anybody that wishes to abstain from this item?
No.
No, can't hear anybody. Anyone that wishes to go against? Okay, then I take it that it's unanimous in favour of the recommendations.
Agreed.
Yes, thank you very much. They're carried.
Right, thank you, Katie. Just to reassure you, after the next item, not saying we should hurry the next item on that, but we are going to have a short break so people can get up and have a cup of tea or coffee. Welcome, Jess. I didn't see you there before. This is the Hampshire welfare response, and I think it's going to be, is it a double act between Graham and Jess, or just Jess?
I think Graham will be displaying the slides for me.
Oh, okay. Right, Jess.
Okay, so this is a description at a high level of all the work completed in collaboration across many organisations to respond to the needs of the most vulnerable in our community. And we're describing this as the welfare response.
I wanted to take the opportunity to pay tribute particularly to our NHS partners who supported, particularly around pharmacy, but also our district council colleagues and very importantly our VCS and the 4,000 Hampshire volunteers who have been absolutely spectacular in supporting and been incredibly flexible around the offer required over the past few weeks and months. So we have been very lucky to have the Hampshire and Isle of Wight Local Resilience Forum to coordinate such a collaboration. And it's enabled us really to be able to escalate issues. We've had to work very closely with MHCLG, particularly with regard to the shielding list. Just to give you a little bit of background, although you're obviously really cognizant of the pervasive impact of COVID over the last few months, it's not only had a disproportionate impact upon existing adults health and care service users, but on a much broader population, as you know. So just to give you some examples, the extremely clinically vulnerable in Hampshire amount to 53,000 people. When we think about people who are not extremely clinically vulnerable, but they are vulnerable and might have been semi-shielding as a response to for example, their age or particular underlying health conditions that they might have. And so that's in addition to the existing much smaller population of adults health and care service users. So it's been very important that we've had some extra help across districts and boroughs and from those volunteers to respond to that group. We've heard a lot about the extremely clinically vulnerable, the shielding list. So the local authorities were tasked with supporting that group who were obviously incredibly limited in terms of their ability to move around and do things for themselves during this period. Of that group, we in Adults Health and Care mobilised a group of people to support us in outward calls. We also, so we had 6,500 people who needed additional support over that time. And then we also had a group of other people who identified themselves as vulnerable and rang our helpline, which was very well publicised, and we had 13,000 people contacting us during this period for support. And they were referred to local response centres who were ably manned by the districts and then referred to volunteer support. And there are a number of people within that group who also needed additional adult social care support as a result of those inquiries, and we have been able to support those people through our business as usual teams within Adults Health and Care. So it won't surprise you to know that one of the primary needs of the group of people phoning us for support have been around food, and certainly the government food boxes, whilst welcomed, have not always provided for people's particular dietary needs, and have also not always been, due to issues with administration, not always been in place for people quite when expected. So the food banks and also districts have been supporting with that food supply in association with the county council. There's also a significant number of people, 32% of people, who needed support with pharmacy delivery. And one of the things that we've been working really closely with the CCG is to support that very individual pharmacy approach in communities where friends and family and neighbours haven't been available. So, as I've already mentioned, amazing collaboration with the 9 community and voluntary sector infrastructure groups working across 11 districts and borough councils with some 4,000 volunteers. I also want to give a special mention there to the carers voluntary sector. So 3 organisations who have really supported carers who've been in a difficult position where some services have had to be changed or temporarily ceased due to social distancing. So putting arrangements in place for that group has been a tall task for adults health and care, and we have been ably supported by carers organisations in that regard. So food supply has been a challenge during this period. I think that it's fair to say that particularly at the beginning of this crisis, there were significant issues around supermarket supply. But I am pleased to say that we've had really, I would say the biggest area where people have paid our collaboration compliments is around the delivery of food. And if you see point 17 in the report gives an example of someone really grateful for that sort of reassurance. And I think also the other thing that I think people have appreciated is those outward bound calls. And I think someone mentioned earlier in the meeting concern around the duplication of calls. Now, we haven't been able to always avoid duplication. We've worked hard to try to do that through working hard on information sharing with the districts and the VCS. However, I would say I'm pleased that we have been able to provide a comprehensive support for people, even when we're missing some information and we do end up in some circumstances phoning people twice. We've taken the view that that is better than that person not receiving a call. But as I said, we tried to streamline what we've been doing as we've moved forward. I think the emerging picture is one where mental health impacts are perhaps more noticeable than at the beginning of COVID, unsurprisingly, after the length of time people have been spending potentially in shielding situations or lockdown situations. We're also seeing an emerging picture around some financial hardship calls and have been able to introduce some financial hardship advice within our call centre expertise. So that's been really positive. We've also seen an increase and have been providing additional support for those experiencing domestic abuse. And I think that's important. It's one of the hidden issues during times such as this. And I think that that's something that we have tried hard to be sensitive to and made sure, particularly that call centre operatives have expertise in those types of areas, and we're clear about where referral routes should be. We're also needed to take a different approach in liaison with MHCRG with regard to rough sleepers and for people with substance misuse issues, and that has been a close collaboration with districts. Moving forward, thinking about stabilisation and recovery, we are moving to a position on the 31st of July where there will be no more food boxes provided for the shielding and obviously from the 6th of July the shielded, subject to their own judgment, of course, are able to leave their homes. However, there's a lot of work to do as part of this to provide a volunteer offer which is a little bit more wide-ranging and perhaps looks more closely at independence enhancement and helping people with issues they might have developed through being at home for so long. We're also formulating and looking at sustained services around mental health and wellbeing for the population in close work with public health. Certainly from an adults health and care perspective, we're supporting carers and looking restoring support, for example, around day opportunities and domiciliary care where people perhaps have decided that they didn't want to do that, or where services had temporarily ceased due to social distancing. we're also continuing to support rough sleepers through the National Homelessness Task Force. And so we're making sure that also we continue to support and talk closely with the VCS, and as many volunteers are returning to employment, and we need to make sure that we are working closely with them to understand capacity, and particularly also thinking about the second wave and our response to outbreak control planning, which may well involve an element of welfare response where somebody is self-isolating. So lots of work to do on recovery, but really the relationships that we have developed with all of those organisations, I think, stands us in a really strong place to move forward positively to the next stages of planning. Thank you.
Thank you, Jess. Any questions for Jess? Anne.
Oh, thank you. We often talk about trying to reach hard-to-reach groups in a wide range of subjects. You said that about 2,800 people had contacted, of which 800 were known to social services. Does that mean that this was a way in of trying to find those hard-to-find groups?
Yes, I mean, we were contacted by a much wider group of older adults, I would say, than we would normally be working with within adults health and care. So I think the helpline was well advertised because we did have good response from that wider population. When we talk about hard to reach groups, we're often also referring to rough sleepers. Certainly we had to have a different way of working with them. They weren't a group that particularly would contact the helpline, but we through the districts who are the lead in this area, we're doing quite lots of proactive work with people who were rough sleeping to make sure that they had a service from us reflecting the problems of COVID-19.
Julie.
Thank you. I mean, do you know, in many ways, this report is a really fantastic story, isn't it? I think, you know, what it evidences is when you have that, you know, shared purpose of coming together, it's been very a very quick and easy response, I suppose, for all of the organisations to come together to address a particular challenge. And I think the challenge to all of us now, whatever sector that we're in, is that we keep that going, because it's going to be necessary, not just if there's about getting people back into some sort of normal life, but if there's a second wave, you know, these services are going to be there. And I don't know whether you were on the call earlier, Jess, but I suppose I want to just reiterate, because you've brought it up in your presentation, is the ask from the voluntary sector is very much to be engaged in those discussions early, very early, in order to try and reopen some of these services. It's going to be a real challenge. It's going to be a challenge, you know, in terms of the spaces that they might have available to them, the distancing, you know, the transport issues, because you won't be able to put groups of people in you know, buses and get them out to these services. But also you mentioned capacity, and I think there's capacity in terms of the people that we need to be able to run these services, and the very real danger that some of these organisations are going to run out of funding very soon. One of the stats that I was given was something like running on 3 months of reserves. That's, you know, that's not going to last that long. Obviously, the voluntary sector itself is taking, you know, as many innovative kind of steps to be able to address that, but it is a real concern in relation to some of the things that you've raised during your presentation and in the report. But, you know, congratulations. Oh, there was one while I've got the floor, there was one thing that I was just going to ask. I know in paragraph 19 it talks about the numbers of referrals and from the different areas, and I know that that's kind of perhaps not truly representative, because you mentioned the fact that there's people that were already getting help, so won't come into these figures. But were there any of those figures that surprised you in relation? So I suppose it's about Anne's point. Are there communities that we haven't reached that may still be vulnerable and that we need to be concerned about? Thank you.
Jess, you're muted.
Sorry, I think that one of the things that we have, so no, I'm not surprised by the figures in that the areas where we have low referrals tended to be the areas where before our response took off, if you like, and was launched, that had become a tradition and a way of working where there was contact through parishes and through individual lines. And what we didn't want to do in working together with districts and boroughs is stop them doing things that already were working in areas, but wanting to supplement that. I guess the casualty is we don't have a comprehensive number then of the fulsomeness of the volunteer and district response. But I think that's important to note. We have really taken a continuous improvement approach to this work, and I think could I say, hand on heart, we are equally accessible to every part of the community? Probably not, but we are continuing to learn and work on that in association with the districts and with the VCS, who are sometimes closer to those things than we are. And I think the sort of piece on rough sleepers, for example, is a good example of that work. So where we're aware of an issue, we really do pursue it. I think there is more work to do. I think particularly with regard to the BAME community within Hampshire, and it's something that we are looking at more fulsomely as part of recovery. But also, just to reassure you, we have got significant voluntary sector contribution and engagement within our recovery groups, and we'll make sure that continues. So they're absolutely partners in planning this, rather than it's something that I hope that would feel like that people are being done onto in with that regard.
Graham, did you want to come in then?
Yeah, just to add to what Jess has said. I mean, I think one of the things, and Jess has already said, that we saw very quickly a wide range of local community-based organisations stepping up to support vulnerable individuals and vulnerable communities. So to some degree, we didn't want to stifle or get in the way of those activities. We wanted to support wherever we could. One of the things that we did put into place through the Local Resilience Forum was the wider Protecting the Vulnerable Residents group. And we absolutely brought in every organisation or representative group to make sure that we had as much line of sight as possible. So, for example, the faith community. We've spoken about the voluntary community sector. We've not mentioned the faith community. The faith community have been absolutely key. And in the county of Hampshire, there are many thousands of good neighbour volunteers who, again, are part and parcel of that voluntary community sector response, which has been very grassroots. And all of that, if you like, is below the line of what we're reporting within this report, because to some degree we can only report on what we know, but we're also very conscious of that additional series actually of armies of support within local communities. It's just been phenomenal. How we capture that, support it, nurture it as we go forward, I think is the sort of $64,000 question.
Thank you, Graham. Philip. Philip, can you unmute yourself?
Sorry, I thought looks good now. Okay, thank you. Really good report, Jess, and it rightly reflects a really positive response. But it was building, as it happens, partly on what Graham had said. In Gosport, we very early on set up a close partnership with Gosport Voluntary Association and the local faith groups. But there was also a huge number of, everything from WhatsApp, street groups all over the place to individuals looking after everybody else. And we managed to identify many more of the rough sleepers than we anticipated, because we early on established 30 really high quality living pods, and that's allowing us to move forward with the groups we've mentioned, hopefully to work with these people as we get ahead. The only time we did have one issue, however, is especially in the early weeks, we were unclear about exactly who was out there that might need our help. we absolutely understood that the shielded list was on very close GDPR hold, but there was a secondary local authority list, because what we were trying to do was establish as clear a picture locally as we could on who was vulnerable, who required support, who was getting it, and I dare say 1 or 2 people who were getting support from 2 or 3 different areas, but we were mainly worried about people falling between the gaps. And it took an inordinate number of weeks before we eventually were able to share with Hampshire County Council the local authority listing. We got it about 10 days ago, I think. I think it's been updated. But we were nervous for quite a number of weeks because we didn't know if what we were seeing from local information actually was also mirrored and from the information that was coming from the government, so the county level. And I think it's sorted, but I would not, if there's a second wave, want to be in that position again of not having as much information that we're entitled to locally as possible. Thank you. But a good response, really good response.
Thank you. I would say that we won't be in that position again, in that I'm pleased to say we do have data sharing agreements now in place, taking into account all of those complexities with the districts. And without wanting to go into too many details, there was a big issue to start with as well, with the fact that a number of people on the shielded list had not registered and given permission for us to share data. So it was a group of people that we needed to be incredibly sensitive with, and in fact had been instructed to be sensitive with by government. But I take on board the fact that that was a problematic area that we had to focus on for a long time to really get it right. But we now have those agreements in place, which is really positive.
Thanks. Graham, did you want to come in on that as well?
Yeah, just to further underline, it was a case where the information and advice from government in terms of GDPR with the clinically vulnerable group and the data that was applied to Hampshire County Council, the guidance was extremely clear in terms of how we had to manage that information. And as Jess has said, it wasn't possible to onward disclose that information without consent. I would have to say, and it's not a criticism, it's an observation, the speed at which government put in place the arrangements in order to make that shielded list available to upper tier local authorities was really quite remarkable. But it was also a case that had local authorities, both the county and the districts, been able to feed in to creating the GDPR arrangements for that information, it would have been a very different flow that we would have seen from the get-go. We've had to almost retrofit.
Thank you, Graham. Barbara, did you want to come in?
Yeah, I mean, the GDPR was a real hassle from the beginning because actually lists were being created from hospital lists. GPs were adding to them. There was an awful lot of work early on to try and clarify who should have been on the list. I just wanted to add, because it's been an amazing response, Jess, so thank you, that the social prescribers that are now front and centre within primary care networks have been really, really supporting these people too, and have been constructed personalised care plans around what matters to me. So I think it's been a great learning curve for all of us, really, and very helpful, and will be ongoing, because actually these people will be joined by an even broader group, as we said earlier, of people who are now more known to be at risk. And there is an algorithm being developed at the moment for NervTag around, so how do we find an increased group around BAME, age, etc., multimorbidity. And so we will be adding to that should there be a local outbreak or a second outbreak nationally.
Right, thank you. Thank you, Jess. Can I ask Katie just to do our sort of, I don't know, voice round to make sure we all agree the recommendations?
Yes, thank you. So there's the recommendations as on page 45 of the pack. Does anybody wish to abstain from this item? No. Anybody wish to vote against? No, I take that as a unanimous in favour then.
Agreed.
Yeah. Brilliant,
Yes.
thank
Agreed.
you. They are carried.
Right, I'm going to actually ask the broadcast to pause for 5 minutes so that people can get up, move around, have a cup of tea or coffee, and then come back.
So the webcast has started. We can go forward.
Okay, super. Thanks. I hope everyone's had a very quick cup of tea or coffee. Can I ask Steve now? There you are, Steve. So it's the Children's Services update now, okay, on COVID.
Hello there. I shall just share the presentation, hoping my technical skills will allow me to do it. Hoping that's coming up on your screen.
Yes.
It is. Okay. So thanks for asking me to do this. And I appreciate there's limited time. So I'm going to walk through this quite quickly. Other members may be aware that this same topic is on the agenda for the Children and Families Select Committee next week. So there are other opportunities to look at this, particularly for elected members. But what I'm going to do is walk you through the response in children's services to COVID. What we've done, this is a theme for the Health and Wellbeing Board, obviously, about starting well, and how we try to mitigate the impact of COVID for children in terms of starting well. And I'll run through the various bits of work that we do, but I will do it at pace, and I'm happy to take questions at the end. Okay, so in terms of our children and families work, this is the safeguarding work and children in care. When we started this, we were worried about the impact of COVID on our staffing, and we came up with a sort of three-phase response. In fact, we never needed to get beyond phase one, which is really positive, and phase one is essentially business as usual, but doing it differently. And that's the key phrase for us. So we're actually in this at the moment. So we are meeting all of our statutory timescales for visits for children and child protection meetings and so on. We're using technology to ensure that we see children through digital means, and our IT services have played a blinder here for us. So we've been able to get things like WhatsApp and Teams onto our phones and computers, because those are the things that young people use, in particular WhatsApp, and families use. So we're able to do virtual visits in many cases. We are doing face-to-face visits as well, and I'll come on to that in a bit. And we've put out a whole load of guidance to our staff about how to do that. We've got phase two and phase three, but we've never needed to go there, which is about managing a reduced level of staff. We've never been phase two kicks in roughly at about 20% of our staffing being absent, but we've never got there or anywhere near there, to be honest. It's been about 10%, 11% max. So we've had to be very quick on our feet in terms of getting guidance out to staff, making sure that they're clear about what the expectations are, what they have to do. That's involved a lot of management oversight, a lot of conversations, helping people to understand what they need to do, and sometimes reassuring people, but getting the business done. In terms of the numbers, you'll see that in March 19 and April 19, we were coming in at around 1,500 referrals in that month. In March 20, that was about the same, but it really fell off a cliff in April. The not so good news for us is that that's now back up. In May it went back up to normal, and as we had predicted and planned for, it's gone up in June, so it's above those levels in June. We're now running at about 15% above our normal rate of referrals, and that probably reflects, and certainly from some of the stuff that we're seeing, it reflects an increase in tensions, an increase in instability within families brought about by the bit lockdown, people being locked up together. You'll see that in April, 53% of visits were undertaken virtually and 47% in person, and that's roughly where we are now. Interestingly, some feedback around that is that young people, teenagers like that. And not surprisingly, really, that's often how they, they have a lot of interface with phones and so forth, and they like that way of working. This is just outline some of the technology we've used and how we've used it. I won't go into too much detail around that. We've been working really closely with our children in care. We've done quizzes, we've done talent shows virtually. We've been supporting our foster carers, obviously, but it's been a hard time in terms of placements. Some children's homes providers that we would normally buy placements from are not open. Children can't move on, or haven't been able to move on when they're 18 and they're ready to move on into their own independent accommodation. Generally, that's not been available for them because of the lockdown. So we've got children staying in care beyond their 18th birthday. And it's been quite a tricky time in terms of matching placements with children. That is likely to continue for the foreseeable future as people have concerns about taking new children into their families. We've worked around our residential estate. We've closed 2 children's homes deliberately because and consolidated the staff into 4. The reason for doing that is, and it's been really helpful, is it gives us more resilience on staff rotas, because you can't have a children's home without having the right amount of staff there. So by having slightly more staff on a particular children's home, we've been able to ensure that we've got a bit of headroom around sickness absence, and that's been really, really important, because that is an area where we have had children that have had suspected cases. In fact, they didn't, but they were poorly. And of course, you can imagine the knock-on effect that has throughout the home. So it's and equally, we've had to support foster carers, some of whom have had suspected cases and so forth. Foster carers have been magnificent throughout and treat the children and have treated the children as their own children effectively. Lots of work with partners, and again, technology has been really helpful in this, and the police have, in particular, for example, have been able to get to 100% of child protection meetings because they're able to do it online. So that's been a really good and positive development. We've done lots and lots of communication with our staff. There's some little screen grabs of videos that we've done to say thank you to our staff and to keep them up to date with what's going on. That's been really well received. And again, it's the use of new technology has really helped us. Again, that use of new technology is covered in this next slide. More frequent meetings and catch-up points. People are working enormously hard and working very long hours in order to get through what we need to get through. Some comments there about the use of social media and video communications from children and from staff, and that's again been very positive. They're not particularly edited comments; they're just what we've had fed back. So those are some of the things that have worked well in children and families. The adaptability, leadership, not travelling so much has been very useful. The use of IT, our creativity and so forth. Hasn't worked so well some sensitive meetings. Got to make sure our staff are equipped for the role, and generally that's been okay. This mode of communication does not work well for non-communicative children with learning difficulties, etc. And it doesn't work well for things like parenting assessments. So again, we've got to think that through as we go into the next phase, and what we do and how we continue to work in a slightly modified environment. I'm going to move through that fairly quickly and just say that's where we are in terms of children and families. But I'm going to move into schools because that's something that affects everybody. Schools were closed at the end of, closed theoretically at the end of March, but open for children, for critical workers and vulnerable children. We worked very hard and continue to work very hard with schools to help them to understand the guidance. And those numbers of children of critical workers and vulnerable pupils have built up. 260 initially, up to 1,800 by May, and I'll come back to why that's an important date. Children with an education, health and care plan, again, the numbers have gradually built up. Not surprisingly, relatively low, but given that those children often have underlying health needs, which make their parents slightly anxious about mixing with other pupils. Just bear with me while I have a sip of coffee. We've risk assessed all those children in terms of their ability to go to school. We've also helped schools set up, well, not set up, their schools have set them up themselves, but we've helped schools with home learning. Schools have autonomy on how to determine this approach. Every school's circumstance will be different. The local authority does not have power to determine and how to tell them how to teach, but we can help them think through the issues and help with some of the methods they might choose. We are in touch with schools every single week. Every single school in Hampshire has a conversation with us, whether they're an academy or a maintained school. We are helping them to strike the balance between the safety of children and staff and the need to get children back in school. And I'll give you some numbers on that in due course. And we've also done support to governors, also, as I say, rapidly produced examples of interpretations of the DfE guidance to help schools say this is what good might look like in these circumstances, and produced a frequently asked questions sheet which is now runs to over 70 pages. So you can imagine how many questions that entails for schools. There's a major focus on well-being for pupils in terms of the support for them. Laptops have been made available by the DfE for children who are open to children's social care, so children who have a social worker, and for disadvantaged in year 10. The laptops for children with a social worker have arrived. The laptops for disadvantaged pupils in year 10 have not yet arrived. And in fact, we cannot order them because they are not, you cannot, until the machines are built and available centrally, you can't order them. So we still wait on that. There's an information cell that's been set up to try and manage all the queries that we get. There's a whole range of guidance, and some of the things that one might think is sort of common sense, or why don't schools do this? They're actually not allowed to do that. An example being that the DfE expressly forbade schools from using church halls, etc. They must work on the premises. So that was a question that came up very frequently, and there are a number of others. 1st of June, then we went to wider reopening in primary. Extensive advice, but there are bubbles of no more than 15 children plus staff. I am aware that there is a new announcement today, but I haven't read it yet. But I'm understanding those bubbles are going to be increased from September. Emphasis on good hygiene. Rotas are not allowed, though that's been very tricky in some areas. There is a priority order of return. Children of critical workers, vulnerable pupils, year R, year 1, and then year 6. And we've been supporting head teachers to think through what that means and how that works. The key restraints on that have been the number of staff and the size of the premises in primary schools in particular. So if you divide your school into 15 bubbles, into bubbles of 15, and you have to have 2 teachers in each bubble, which you do, then you very quickly run out of teachers, especially if you've got some teachers that are shielding or are unwell for other, for COVID or other reasons. So that's been very, very difficult. And then you've also got the issue of how do you fit those pupils that you get into the school physically. Despite that, in primary, we've had over 25,000 pupils return since the 1st of June, which is incredibly impressive. It's one of the highest numbers in the country of pupils back in school. Moving on, the 15th of June, there's a wider reopening in secondary when year 10s will come in, but only 25% on site at any one time. That's the guidance. And we've now got to, so not on there, we've now got about 38,000 pupils were in school last week in Hampshire, which includes year 10. There are plans in place for the awarding of GCSEs and A-levels this year, which will essentially, the easiest way to describe it is based upon the last 3 years' results in the schools, and then the pupils are ranked. In other bits of service where it's business as usual but doing things differently, as I've described earlier. Moving on to the sort of more long-term work in schools, we do a lot of work around building schools and maintaining schools, and the majority of construction sites remained open, adhering to government guidance where it's possible, where work was possible and could be adhered to government guidance. That's what we did. A few sites were closed, but now all are reopened and back on track essentially. There's an issue about productivity in those, which we'll deal with through contracts and so forth. But our new school place schemes are on track for delivery in September 20. One of those is Barton Farm, and I haven't got the other one in my head, but there's another one that is due to open. I think it's in Chandler's Ford. In terms of our other work, there's a lot of activity as support work, if you like, but the areas most affected have been homeschool, transport and early years, and I'll just give you a quick whiz through some of those. Generally, we're transporting around about 9,000 mainstream pupils and 3,000 pupils with special educational needs. Now, if you think back to what I said about pupils being in bubbles and how that then overlaps with transport to school, it is a bit of a nightmare. And if you then overlap onto that the social distancing requirements in terms of travel, it's very, very difficult. Transport principles that we've shared with schools is that parents should take children to school wherever possible, and that parents have been on side about that generally. We're effectively using about 25% of capacity in some of our larger vehicles, because that's all you can fit in a socially distanced way. In theory, that could lead to, if these restrictions were still in place in September, and we don't know whether they will be, that could lead to some very significant additional costs, except that the reality is that there simply aren't enough buses and taxis in Hampshire to provide additional services. So there's a real problem here. So we're looking at the ways in which we can stagger starts and so forth to get all of the children in, so you do more than one bus journey. I have to say that we don't yet know whether all of the current restrictions will be in place in September. So I'm optimistic that actually there will be a different set of solutions that we'll be able to find when we're clearer about what those restrictions are. And I won't labour those points. During all this, we had the school admissions rounds to complete, which we did. 98% of parents been offered a reception year place for their child, one of their preferred schools, and 99% received a place at their transfer school. So again, really good parental choice in Hampshire, and we managed to keep that bit of business as usual going throughout the whole scheme. And the last area that I want to just major on for a little bit is early years and the childcare market, and there's been some attention on this recently. Let me just take another slurp of coffee. And this is obviously important as the country gets back to work. Many people need childcare arrangements, and the advice originally was not terribly clear, and it's always quite a fragile market. There are lots of players in that market. You can see from this this graph there are nearly 1,500 providers in Hampshire, and most of those providers, in fact the vast majority, have a mix of privately funded, i.e. people who pay for their childcare, and some state funded through the 15 and 30 hours guarantees. And of course, we can continue to guarantee the state funding. That came to us through the DfE, and we've guaranteed that. But of course, those providers lose their private income, and that's really damaging. You can see that there are 199 providers where their private income is between 80 and 99%. So that's a real issue for them, and furlough overlapped onto that. I won't go through all the details of it, and DfE changed their guidance at a certain point. But what we've done as a local authority is try to create a brokerage service. So parents contact us, and you can see we've been having sometimes between 50 and 100 inquiries per day. Parents contact us. If their provider is not open for whatever reason, we can then try to broker them with another provider. It's not perfect. It's not for lots of reasons. The children don't necessarily know their provider. They may have a pre-existing relationship, and it may be further to go. But at the moment, we're getting through, and we're optimistic because more providers are coming back into the market, that we will have sufficient capacity. It comes September in particular. But it's been a hard work to get all those things sorted in a very short time scale. So there we go. Those are the challenges as we go forward. That's it. That was my very quick run through. I hope that was quick enough, Liz, to get us through it. I'm very happy to take questions. Yeah, there we go. You're still muted, Liz.
Yeah, sorry, I didn't mean to be muted. Steve, thank you very much, and I'm sorry you had to rush through all that. Perhaps we should have allowed longer time next time. Yes.
Well, there's no worry. I'm happy to go. I'm always happy to go quickly. You know me.
Any questions for Steve? Anne.
Just a quick question. You mentioned one of the challenges you had was the courts were out of step with the staff requirements. Has that been a major problem?
Well, it was for a bit, and then they changed. There was a discussion and a negotiation. There were some expectations on local authorities that we were going to provide all families with laptops and so on, so that they could engage with the courts. And we said, no, we can't do that. It's just not on. There are other ways to do that. And eventually we've negotiated a way through that. And so we're now in a better place with the courts, but it was tricky for a while.
Okay, Judith?
Thank you. Yes, Steve, you mentioned the continuing, if I can put it that way, education of children during lockdown by schools, and you emphasised the fact that in that regard schools have autonomy. So it's obviously not something that we can measure, but will there be any reports on how schools performed so that there can be some sort of scrutiny and learning from the sort of education that took place?
Yes, there will be, and I'm party to some discussions through my professional association, which is the Association of Directors of Children's Services, with Ofsted. And Amanda Spielman has gone on record as saying that, and I paraphrase, but that there need to be standards developed around online learning, and because there aren't any at the moment, and sort of understandable really, because it's not something that anybody's had to face before. Because Ofsted inspect against standards. So it's the DfE that have to create the standards and Ofsted inspect against them. And she's called for that. I understand that is likely to happen, or some version of that is likely to happen. And also that Ofsted will are likely, be careful what I say, likely to do some form of assurance type visits to look at how schools have coped with COVID and develop and highlight best practice and things that can improve. It won't be an inspection, as I understand it, as such, but it would be a sort of investigation into how things might have done, what might have worked well, rather like you've seen me do, and what's not worked so well, and take the lessons from that. From our own perspective, we'll also do that locally, and we've got some views on that, and we've seen some really good examples, and we share that where we can. We've produced a number of sort of good practice guides, if you like, and including we're developing one around online learning, which should be ready to go any day now, so that schools can sort of share across what works well. There are, though, it's an imperfect teaching method. That we have to be clear about that. It's not something that is pedagogically sound, and it's particularly not in the primary sector, where there's very little evidence that supports online learning as being very useful for young children. Other methods actually are probably more useful, such as workbooks and so on, because they're more interactive. Anyway, but that's getting into the weeds. But yes, it's certainly something we need to look at, something that Ofsted are looking at, and schools will be reflecting on it themselves as well.
Thanks. It's just that I mean, I don't want members here this morning to think that we're morphing into the Children and Young People Select Committee, but of course, how children have been engaged and to what extent will have an impact on their mental health going forward. So, which is why I asked the question.
No, it's absolutely right, because that's exactly the point. Is that their engagement or disengagement with school is critical to their well-being.
Thank you.
I don't think there's any other questions, but I did see a note from Barbara, I think it was Barbara, asking about provision for key workers through the summer. Do we take any action on that?
Right.
Sorry, Steve.
The note that we received guidance from the DfE yesterday, which said that schools are not going to be expected to open through the summer. There is also, last night arrived some guidance around summer schemes and play schemes for the summer. Haven't got into that yet, I have to say, I haven't had a chance. The previous guidance was very unhelpful because it stated that you could only have 4 children and 2 adults. I'm sincerely hoping that the new guidance, when we get to it, my colleagues will be looking at it now, but was very much hoping that gives more leeway to larger bubbles, which will enable providers to create more schemes. Almost all of those schemes are privately created. They're often offshoots of schools, but the problem for them is that if the guidance says you can only have a group of 4 children and 2 adults, as it did, for them to do anything different from that would invalidate their insurance, and at which point they don't have a viable scheme. So that's why we're so dependent upon the guidance being useful and helping providers to set up the schemes, because there are providers who want to do stuff that it's just about making it feasible. I'm afraid I just haven't got the detail of that. I think I dropped in my inbox about 8 o'clock last night.
Thanks, Steve. Julie.
Yeah, just a couple of things that struck me while you were talking. It's not going to resolve your transport challenges, which I have been discussing with colleagues over the last couple of days. But certainly, Steve, I was just wondering how closely we're working with the My Journey team and thinking about that return to school for particularly in September, around the walking, cycling, as a building on those kind of, that's a safer way, avoiding public transport, etc. There may be an opportunity in there. On the summer scheme, play schemes and so on, we've also had notification through the physical activity sector that there's funding coming down the line for that. And, but like you, we have not had detailed conversations with providers. Some of that is built in with the kind of fit and fed as well. So we're working with colleagues across the area, but I haven't got any more detail on that. There was a third thing, but that's now gone out of my head. So, oh, I know what it was. Just in terms of the guidelines that are being developed to help schools and so on, I just wondered whether colleagues were building into that around that kind of mental recovery of our children and young people, and thinking about, I know I've seen some pictures and articles around that, you know, kind of outdoor learning, just building in space and time for children to, you know, I suppose acclimatise back into school, express how they felt through this period and so on. And I think that would be helpful to be built into the guidance. I'm sure it's been taken into consideration, but yeah, I think that's going to be very important.
Yeah, thanks, Judy. I'll do those in reverse order if I can. In terms of the, we've actually talked quite a lot to schools about what we probably wouldn't use it publicly, but what we're calling recovery curriculum, doing exactly those things, giving children time, and also particularly if they're younger children, time and space to talk about their experience in lockdown, and then what it's like to be back at school, and then how they can get back into learning, what they missed, all of that. So yes, definitely agree, and we are absolutely building that in. Summer schemes, I agree, but we're in the same place on that one, so I think that's fine. School journeys, absolutely. I get into terrible trouble though, as some people around the table will attest, when people think that I'm taking away their right to free transport. So we have to be careful about that. People will also be keen to ensure that they continue to maintain their rights. So we always try to encourage, as you rightly say, free walk to school if you can, cycle, healthy means of getting to school is the best way, if possible.
Thanks, Steve. Alex, did you want to come in?
I've just put it on the chat as well. It's just to say that the summer placement things are absolutely crucial to our NHS, our ability to staff the NHS over the summer. You know, we have an awful lot of parents who work in the NHS. So anything we can do to help with the guidance, or, you know, influence people or petition people, or what, you know, anything we could do, then just let us know, because it's crucial to our workforce.
Absolutely, and we've been playing that back to the Department for Education very, very, very hard.
Brilliant. Thank you.
We've got that message and we completely understand it. Yeah.
Thank you.
Right. Thank you, Steve. And I'm sorry it was such a canter through for you. Katie, do you want to just do your usual verbal voting?
Thank you. Yes. So we just got the one recommendation to note the update. So is everybody happy to note the update from Steve?
Yes.
Brilliant. Thank you very much.
Thank you, Steve. Thank you. Christine, co-production update. Can I just give you 5 minutes for this so we can try and play a little bit of catch up on time? I'm not trying to say it's not important. It is important. But I know that a paper will be coming back later to the board. So if you could just give us a very quick update. Christine? Have we lost her?
I'm just trying to sort myself out. Yes, hello. You'll remember at the last meeting I felt rather indignant because, having made various commitments to working on co-production, what's now more than 2 years ago, I realised we hadn't made very much progress. So I had a really helpful meeting with colleagues from Adult Health and Care, and we've come up with some extremely practical proposals which we hope will embed things in the Health and Wellbeing Board activities in future. I want to emphasise that we're not trying to say to people, you must involve the public in this way or that way. We're not trying to set down clear rules about how to do it. What we're trying to do is to say that the Health and Wellbeing Board itself had already 2 years ago accepted responsibility, or noted that it had responsibility for making sure that the patient and the public's voice was heard. And so this is just a way of trying to work out how to achieve that. I can cut and paste what we're saying into the chat so that it's easier for you to see what's going on. So I will just do that now, and then I can talk it through if it's not coming up. Right, here we are. Basically, it's very simple. We're saying we ought to amend the template for reports to the board so that there's a section in which people have to explain how co-production is being reflected in the recommendations and the conclusions, and that the board needs to keep an eye on that to make sure that people do actually fill it out in a way that makes sense. We're asking for co-production to be embedded across all the health and wellbeing board's activities by asking the sponsor of each theme to be responsible for making sure that it's embedded. And that whenever the board looks at a theme in detail, we make sure that we have co-production as part of that examination. I learned that the chair of Hampshire's personalisation expert panel has actually already been looking at the adult health and care co-production strategy and is planning to report with some recommendations. And we thought it would be a good idea to bring that report to the board so that the board could see both what adult health and care are doing and also what the user panel thought about it and what their suggestions were, because it would be interesting for everybody to see, pick up good ideas and indeed maybe have some suggestions. We're going to send round a note linking to various good practice guidance, because the more people have got, the better. And when there's a new sponsor for strategic leadership, which I hope is going to be soon, we're going to ask them, because co-production is one of the strategic leadership themes, to look to how to reinforce a culture of co-production and shared learning across health and social care. And we're also going to ask them to make sure that these recommendations actually get implemented. I originally said by the next meeting, i.e. 1st of October, but it was pointed out to me that they might not be appointed in time. So please let us know when they're going to be appointed and we can work out whether it needs to be the next meeting or the meeting after next. And finally, we're going to have an overall action tracker so that the board knows where it's at, not with co-production, but also with everything else, so that we don't end up with making decisions and then not implementing them. So that's all the ideas that we thought of as a way of making sure that things get properly embedded without an enormous amount of conversation about how to do it.
Thank you, Christine. That was very quick, so thank you very much. Has anyone got any questions for Christine, or are we just happy to note the verbal update? Oh, Graham. Graham, yeah. You want to say something?
Thank you, Councillor Fairhurst. Just to say that I support and endorse that approach that Christine has set out, and happy to note as well.
Okay.
Thank you, Graham.
Right. Everyone else happy? We'll move on. Anne, I think we're coming to you for your report on housing and health.
Thank you. One of the actions in the Health and Wellbeing Board business plan was to undertake a Healthy Homes Needs Assessment. And I'm pleased to say that this has now been done. And following on from that, a Healthy Homes workshop, which was hosted by the Districts Forum in collaboration with Public Health, was held. I therefore pleasure in bringing this report to the board today on behalf of the Districts Forum in conjunction with Simon Bryant, the Director of Public Health, which summarises the findings and outlines the key actions that have been identified for further development. You'll see that the report focuses on building the right homes, training and development, accessible homes, including home adaptations through the Disabled Facilities Grant and hoarding. The report has 5 recommendations, which are the first steps to implementing the required actions. Underpinning these priorities is the need to work collaboratively and explore joint initiatives, including shared training programmes and promoting information on existing schemes and other forums, such as the Hampshire-wide Hoarding Forum. There's also considerable alignment between these actions and those being discussed within the Hampshire and Isle of Wight Sustainability and Transformation Partnership. We now have our Hampshire District's Health and Wellbeing Project Officer in place, I'm pleased to say. Rosie Fowler is working 2 days a week to drive forward the Healthier Communities agenda and to maximise collaboration across the county. A multi-agency Healthy Homes working group has been set up to drive forward our key priorities, and their first meeting will be on the 7th of July. Implementing the actions in the report will support the Health and Wellbeing Board meet the outcomes of the strategy and the Better Care Fund policy. Therefore, we would like the Hampshire Health and Wellbeing Board to support these recommendations.
Thank you, Anne. Any questions for Anne? Simon.
I was just going to come in and really support Anne and thank her and the group for doing this. And it's probably the first kind of way we've kind of moved a little bit further away from kind of traditional health and well-being and really thought about a kind of wider agenda. So I'm really excited that we're taking this forward, and I really want to support that. So thank you, Anne, for presenting it.
Graham.
Yeah, thank you, Anne. I think it's a really helpful report, and thank you for presenting it in the way that you did. Again, I really endorse this. I think there's also an additional element for me, though, as well, which is a consequence of COVID and the way that both at a county, an NHS, and a district and borough level, we've worked collaboratively and differently in response to COVID, which I think actually is the opportunity as we go forward. And indeed, because of the requirement upon district and borough council partners as the relevant housing authorities in the county around rough sleepers and homelessness, there are some really positive conversations that are now taking place with regard to DFG, but also Homes for Life and so on and so forth. From a Director of Adult Social Services perspective, given that the occupational therapists and indeed other colleagues from within my services support district and borough council partners around DFG, I think there's a number of areas of collaborative work that we've identified to go forward, which I think will only further support what you've outlined within this report. So really, really pleased and happy to endorse.
Thank you.
Thank you, Graham. Philip.
Yeah, thank you. Yeah, absolutely a super report. I was very disappointed I missed the first workshop. So this may be just because I didn't have full sight, but the one mark I would put down is, of course, a number of large parts of Hampshire have very historic town centres and areas where a lot of the report talks about new build and the rest, covers adaptation and the rest. And the only mark, and I hope it will come up at the second workshop, in some of the areas where there are the largest health inequalities, they're not in line for huge new builds. So there's still need to be a sustained effort to address the shortcomings in the wider community design existing in those places, because it's not going to be changed instantly. That's all, just a marker for the future. Thank you.
Thanks, Philip. Barbara.
Just to endorse your report, Anne, and to say actually that the work that COVID has brought, as Graham said, to working locally in a natural community of care, so within districts and boroughs, with primary care networks, particularly with regard to shielding and vulnerable patients, and the wellness support that's been offered with the voluntary sector as well, has been brilliant and really needs to be built upon. So that's fantastic. Thank you.
Right, well, thank you very much, Anne, for all your work, especially with the district forums. I think you've done a tremendous job. Thank you. I think we're meant to have another verbal vote, but is everyone in agreement?
Agreed.
Yeah, I can see lots of hands up, so we'll take that. Okay. Last item, it was not brought policy. And I think we've got Debbie McGregor in.
Yes, thank you, Councillor.
Welcome, Debbie.
Thank you. Yes, so just to provide a brief overview, I'm hoping that these resources were sent with the board papers for your review. So these resources were designed and developed as it was hoped that they might be able to form part of the early intervention prevention agenda for safeguarding adults. Very conscious that within the safeguarding children's arena, they already have resources for families and professionals when children aren't brought to their appointments. So the resources were reviewed at the Hampshire Safeguarding Adult Board subgroup. There were actually 4 LSAB subgroups, apologies. They did go to the health subgroup, and the resources were last reviewed by the policy subgroup at the beginning of the year. However, a decision was made that the board didn't feel that they could endorse it. They felt that it didn't perhaps sit right within the safeguarding arena. It led to a discussion with the board manager as to would this be something that the Health and Wellbeing Board may wish to consider. To provide a brief summary, they were designed as 1-minute guides, one with a focus on professionals and clinicians, the second more for families and carers. And the key areas that we wanted to highlight was the need for professionals to work together and share information appropriately, and also for the need to have professional curiosity. We know that there is a danger that organisations may engage their disengagement policies without actually fully checking why an adult with needs for care and support hasn't attended their appointment. But also it's very much focusing on what the impact is to that individual if they have missed particularly a number of appointments in terms of maintaining their health and well-being. So really it was just to ask the board members to consider that whilst it's acknowledged that there may be some tweaks to be made in terms of logos, because obviously it was designed as part of the initially Safeguarding Adults Board work, whether the resources might be helpful in terms of the wider health and wellbeing agenda. Thank you.
Absolutely. Thank you, Debbie. Julie, you want to come in?
Yeah, Debbie, can I just, for clarification really, when I looked at these resources, it talks about adults, but very much the images and the references to the voluntary sector organisations that can support these adults is very much around older people, so Age UK, Age Concern. I'm presuming that there's a whole raft of other adults that would come into this area, and just, you know, want to know whether this was pitched specifically at older people or was it adults per se, and also to that point, and it's something that I've been doing just recently, has this been run by, has it been, you know, effectively market tested maybe by some people that, you know, professionals and carers and adults who, you know, you want this leaflet to speak to? Thank you.
So, okay, so in terms of answering your first point was in terms of some of the images used, that's something that again we could review to make sure it encompassed a wider audience. In terms of feedback from the leaflets, as I say, it's been widely shared through the Safeguarding Board's governance routes. It hasn't been to through a stakeholder group for that feedback.
Did you want to come back, Julie, or are you happy?
Well, I mean, you know, I'm looking at this and I'm looking at, you know, this is, you know, not something that I'm looking at for me or anybody, but if I was looking at it, this leaflet wouldn't speak to me if it was aimed at me, if you see what I mean. So, you know, the principle is brilliant, but I'm not sure we've got it spot on yet.
Okay.
That's what I would say. Maybe. I don't know what others think who might have a little bit more expertise in this area. Thank you.
Simon, do you want to add anything? Did you want to come in?
Yeah, thank you, Councillor Hurst. Yeah, I mean, I think for me, there's something about being clear what the purpose is, and I can see that the safeguarding of vulnerable adults is an absolute key part of health and wellbeing. But as we've brought into a slightly different agenda, it slightly has different meanings. So prevention of what, and I think it's probably prevention further damage, and just being really clear, because I'm thinking some of the areas I lead on, do we really want the smoking service to take this up? It's actually been really clear what we're trying to achieve with this, and children's safeguarding is a little bit clearer. This might need a little bit more thought before we say, yes, this is the right way, if it's going through the Health and Wellbeing Board, and how we just do that.
Okay, all right, thank you.
Graham.
Yeah, thank you. As chair of the Hampshire Safeguarding Adults Board, it would be rather remiss of me not to comment. And I guess I'd want to say essentially two things. I think in terms of the aim of the was not brought policy, it's absolutely the right thing to seek to make colleagues, professionals and others aware of. The other comments are that, of course, this is a collaboration across the 4 local Safeguarding Adults boards, but I absolutely take on board Julie's comments in terms of the imagery and the need just to test. So as chair of the board, I will absolutely make sure, along with colleagues, that that's what we look to do. But I would want this board, notwithstanding comments that both Julie and Simon have made, to kind of endorse the principle of what the 4 local Safeguarding Adults boards are seeking to do. In terms of that professional curiosity, that's the vital thing. It's asking the next question rather than let things lie. And that's what we're trying to promulgate and promote through this particular approach. Thank you.
Thank you, Graham. I think that's well said. Debbie, do you want to come back? Or
I think it was very much, Councillor, to present to members of the board to ask for feedback. I think it is acknowledging that, it needs to be fit for purpose. It needs to be very clear in terms of what it's seeking. So if I could be supported to do that, I'm very happy to take that away, make the necessary amendments and to bring it back for sign off if it was felt useful.
Thank you. That would be really good. Simon, did you re-raise your hand or has it just stayed up?
Sorry, it's a lazy hand. It should go down.
It should go down. Okay. Thank you. So yes, we'll welcome you back, hopefully in October.
Okay.
Would that be acceptable?
That's perfect. Thank you. Thank you very much.
That is brilliant. Our next formal meeting, hopefully in person, is due on the 2nd of October. And I hope that we will all be able to be present then in Winchester. But thank you all very much for your attendance today. And once again, I apologise for the meeting running on so late, but thank you all very much. Thank you.
Thank you.